Alright, so I will be going over Chapter 42, Care of Patients with Problems of the Central Nervous System, the Brain. Migraine headaches are the first disorder that we'll talk about. Migraine headaches are common, recurrent attacks of head pain that serve no purpose. Migraine headaches are throbbing. They're typically unilateral. The patient can experience nausea, sensitivity to light, sound, or sensitive to head movement. The migraine headaches can last 4 to 72 hours. Migraine headaches are familial. Women are more at risk, and migraine headaches also place the individual at risk for stroke and epilepsy. It's not completely clear what causes migraine headaches. There are several factors that play a role. Experts say that migraines are neurogenic. MSGs, caffeine, and red wine can be causative factors for headaches. There are 3 subcategories that fall under migraine headaches. There are migraines with auras, migraines without auras, and atypical migraine headaches. Migraines with auras, there are 3 different phases of migraines with auras. And migraines with auras, these are preceded typically by visual disturbances. During the first phase, the aura can last 1 minute to 1 hour. Neurologic changes can occur, such as drowsiness, aphasia, vertigo, numbness or tingling of the lips. In the second phase, the pain typically begins in the temple. And for the third phase, pain changes from throbbing to dull. In migraines without auras, these are typically known as a common migraine, and they are frontotemporal. Pain is unilateral and pulsating. Patient typically has photophobia and phonophobia, and they last for about 4 to 72 hours. Typically, migraines can come on in the early morning, during periods of stress, because of premenstrual tension or fluid retention. Atypical migraines are less common, and these include menstrual and cluster migraines. Interventions for migraine headaches, we have pain management through drug therapy. Headaches can reoccur as a side effect of some drugs, and this is considered a medication overuse headache or rebound headache. The drugs that are for migraine headaches are triptan, ergotamine, and isometheptine. Triptan activates serotonin receptors. It's important to know that triptan is contraindicated in individuals with high blood pressure, ischemic heart disease, and peripheral vascular disease. For triptan users, they want to take the pill as soon as the symptoms develop, and triptan should not be taken with SSRIs. Ergotamine should be taken at the start of a headache. Midrin is a combination pill. Typically, it's the most common pill that's given for migraines. There are preventative drugs that can be taken, beta blockers, but only propranolol and timolol can be taken as preventative. And we must instruct the patients to take the pills as prescribed, and that beta blockers can lower heart rate and blood pressure. Beta blockers are used as an off-label. Anti-epileptics are also used in preventative measures. Anti-epileptics, the mechanism is not clear for what those do. There are complementary and alternative therapies such as acupuncture, yoga, and meditation. If you look at page 857, chart 40-3 and 42-3, and look over that. The next headaches that we'll talk about are cluster headaches. Cluster headaches are manifested by intense unilateral pain that occurs without warning, typically in the spring and fall. These last 30 minutes to 2 hours. Cluster headaches are the most common short duration headache. They are less common than migraines, though. Cluster headaches typically develop in men between 20 and 50 years of age. The cause is unknown, but imaging relates cluster headaches to an enlarged hypothalamus. Cluster headaches are typically excruciating. The pain is non-throbbing. The pain is typically felt deep in and around the eye. Pain can radiate to the cheek, ear, neck, and temple. They can occur at the same time for about 4 to 12 weeks, followed by a period of remission that can last up to 1 year. The temporal artery can be prominent and tender in these patients. There is typically ipsilateral tearing of the eye, rhinorrhea, which is a runny nose, ptosis, eyelid edema, facial sweating, and miosis. Miosis is constriction of the pupils. When we are communicating with these patients, we need to identify if their headaches are from emotional or behavioral factors. We need to know if the headaches are occurring from excitement, excessive physical activity, or bursts of anger. Note the patient's sleep-wake cycle. Is there a lack of sleep, or are they going to bed and waking up at the same times each day? Interventions for these patients, it's very important to explain important sleep-wake cycles. Drug therapy. We need to instruct these patients to wear sunglasses during an attack. And high-flow oxygen, 12 liters per minute, can be prescribed for 15 to 20 minutes. High-flow oxygen inhibits the activity of carotid bodies and reduces the vasoreactivity of cerebral blood vessels to neurogenic stimuli. Surgery may be needed for these patients if drug therapy does not work. In the next audio, I will start with seizures and epilepsy.